All right, so my name is Stephanie. I am a fourth year medical student at the University of Iowa, Carver College of Medicine. And today I'll be presenting on postmenopausal bleeding. And this is actually my last virtual round session that I'll be doing. So I will be heading into residency in a couple months. So I just matched internal medicine at Mayo Clinic. And so I want a little bit of downtime to just, relax and get ready for things. So, but this has been such a fun opportunity, and I've really enjoyed getting to make these cases and work with you guys on this stuff. So yeah, thank you. Thank you. All right. So as always, if you have your SOAP note, you can go ahead and open it up and get ready to take notes or whatever, however you want to use it. Put it in the chat if you do not have access, and we will get you a link. But looks like this, and you guys I think most of you are familiar with this at this point, but okay. My computer's being finicky, sorry. Okay. So our case today is about postmenopausal bleeding. So I'll go ahead and put up the first couple paragraphs and let you guys read through it on your own.
What's cisgender?
Yeah, so this is saying she has been, she was born as a female and she identifies as a female, like female gender. So her sex was female at birth, and then she also identifies as like a woman and a female.
Got it.
Great question, though. Okay, so question for you guys. So this looks like this is the lady coming in that's postmenopausal. She's had 2 weeks of vaginal bleeding. So does anybody know what is menopause and what are some symptoms of menopause? Sorry, this is my first virtual round. Can you explain how to use the SOAP notes real quick? Yeah, thank you for asking. Let's go back real quickly. Sorry. Why is this not letting me go? Hold on. All right, there we go. Okay, so yeah, as we walk through this, so traditionally when we present patients, when we interview patients, we do things organized as like SOAP, which is subjective, objective, assessment, and plan. Sometimes these cases that I write don't follow that specifically the whole time, because I weave in learning points as we go along as well. But really, it's just a chance for you to take notes as we present the case. So for example, subjective is going to be, what does the patient have concerns about today? Why is the patient coming in? In this case, this is somebody who's coming in with vaginal bleeding. So you could write down, 2 weeks of vaginal bleeding. And as we get more history, you'll write down more about what the patient is subjectively experiencing. And then objective will be things like physical exam, vitals, any laboratory results we get, any imaging results we get, that sort of thing. So that's a place for you to take those notes. And then assessment and plan will be where we kind of wrap things up and we take our differential diagnosis that we've made and we come up with, okay, well, what do we think that this patient has, based on the objective data and the subjective data? And then what are we going to do about it, the plan? So what's going to be the treatment or what's going to be the intervention that we do? So yeah, really just a place for you to take notes. And I see someone said, can someone send a quiz link? And someone did. Thank you guys so much. So yeah, at the end of your SOAP note, once you fill it out, you'll be able to access the quiz, and then you can have a chance to take the quiz. I think you can take it more than once. And if you get 80% or more, then you get the certificate and whatnot. So, but yeah, great question. Thanks for asking. All right. So back to the case. Oops. Okay, so what is menopause and what are some symptoms of menopause?
Do we just shout out?
Yeah. And so you can shout out the answer and unmute yourself if you want. Sometimes people like to just put it in the chat, and that's fine as well. I'll be monitoring the chat and make sure I look at those. But whatever you're comfortable with. So already in the chat, we have some symptoms of menopause, which are like hot flashes, you can get chills. Yes, temperature disturbances are definitely symptoms of menopause. So does anybody know like what menopause is specifically, or what classifies menopause?
It's when older women stop experiencing the menstrual cycle.
Yeah, absolutely. Yep. No more menstruation is something we have in the chat as well. So great. Absolutely. And menopause actually is when you've stopped experiencing the menstrual cycle for more than 12 months at a time. So usually it takes like women, it can take them multiple years to go through menopause because, maybe they don't have they're getting close to like late 40s and they stop having their period, and then 3 months later another period comes, so technically that's not menopause, but then it starts getting spacing out longer, it starts becoming irregular, and eventually they don't have a period anymore. And then after 12 months, so 12 months from that point would be classified as being postmenopausal, so being postmenopausal. Great. And then we've already talked about some symptoms of menopause like hot flashes and chills. Do you guys know what hormone, the absence or like the lack of the hormone, like decreasing levels of the hormone, is responsible for causing the symptoms of menopause?
Is it estrogen?
Yeah, absolutely. It's estrogen. And so females, when they go through menopause, their estrogen will decrease. Their ovaries, they'll stop like ovulating and things like that, obviously, because they're not having the cycle. But that can cause a lot of those postmenopausal symptoms as well. It can cause like atrophy of the vaginal tissue. And so women can experience things like dryness, pain during intercourse. And then also the hot flashes are a really big symptom that many women have concerns with when they go through menopause. So great. Let's go. Okay, so just a little bit about, again, to recap what menopause is. So it is a normal process, right? It occurs as the ovaries in women or females are depleted of follicles and they produce less estrogen. And then that causes all of these symptoms. The median age of menopause is about 51.3 years in the US, but it can be anywhere from like 40 to 58 years of age. So pretty wide range there. And like I said, it's a natural process that takes, several years because your periods start to become more irregular, and then like the spacing out, maybe 3 months, then 6 months, whatever. But really, you can only be diagnosed as postmenopausal when you have not had a menstrual cycle for more than 12 months. Okay. So before we get more into the case, let's just get a little bit of background about like the uterus, the endometrium, and the menstrual cycle, because I think that this will help a lot with understanding some things as we move forward. And the menstrual cycle, even as, a female myself identifying as a woman, it's like something that in med school I've had to constantly relearn because it can be pretty tricky. So I don't want you guys to get all like, caught up in all the details here, but just understand the big picture. So really, there are multiple hormones at play throughout the menstrual cycle. So some of those being estrogen and progesterone, those are being like your main ones that will influence the growth of the endometrium, or like the stabilization of the endometrium. And then we have some hormones released by our brain, luteinizing hormone, which helps to cause ovulation, and follicle stimulating hormone, which helps like develop that follicle that egg is going to be in. So what I want you to pay most attention to on these next few slides is the endometrium here, okay? So the reason that we bleed when we have menses is because the endometrial lining is what is undergoing changes during the menstrual cycle. So if we look here at the uterus, this is the uterus. Here we've got like our two ovaries. We've got like the inside of the uterus. This will be like the opening here. We have the cervix. The vagina leads into the cervix, and the cervix leads into the uterus. Now, the endometrium here is this innermost lining of the uterus, okay? So it's close to the cavity. So it's the innermost lining, sort of lateral to that is going to be your myometrium, which is your uterine muscle. And then you have this perimetrium is kind of like the outside of it. So the endometrium is what's growing and changing during the menstrual cycle. And the first phase is the follicular or the proliferative phase. Okay, so your menstrual cycle, it can vary in length, but typically for females, it's about 3 weeks to a month. The follicular phase is the phase that will vary in length. So approximately days 1 to 13 is this phase, the follicular phase. It's under the control of estrogen. So I want you to remember that during the follicular phase, the growth of the endometrium is under the control of estrogen. And the whole point of this phase, as far as the endometrium goes, is to grow that endometrium, to get it ready for possible, pregnancy, right? So during this phase, that's when our endometrium is really going to grow and become the thickest. Okay, so that's another important point. So follicular phase under the control of estrogen, and it becomes the thickest in this phase. Then we enter the luteal or the secretory phase. So around days 14 to 18, under the control of progesterone, the endometrium here is going to become it's already thickened from the follicular phase, but here there's going to be an increase in microvasculature. So depending on whether or not, and I forgot to say, but ovulation kind of occurs right at that end of the follicular phase. So that's when the egg is going to be released. So in the luteal phase, we're kind of just waiting. The endometrium's kind of just chilling to see if is there going to be implantation, right? Did this, female become pregnant? And so growth of all of those microvasculature is really helping the endometrium to prepare for possible implantation. Now, if implantation does not occur, progesterone is going to fall. And that fall in progesterone is telling the endometrium, hey, implantation did not occur, so we don't need to be, preparing to have to carry a baby anymore. And what happens is that endometrium sort of sloughs off. And that sloughing off the endometrium is what the menses is. That is what the bleeding is, okay? And then we just go through the cycle again and again. So that was a lot of words, a lot to think about, but really just to recap, there are 3 endometrial phases throughout the cycle. There's the follicular phase. It's under the control of estrogen. It's when we're growing this endometrium. The luteal phase, we're waiting to see, hey, did the egg implant, did an embryo form? And then progesterone is going to fall if pregnancy did not occur. And then that's menses. And so menses is where you'll have the bleeding and the sloughing off. Okay. Great. All right. So knowing all of that if a woman has undergone menopause, what do you guys think? Should she still experience bleeding from the vagina or menses?
No.
Yeah, right. I mean, the whole point of menopause is pause on menstruation, right? So, and vaginal bleeding in general is not normal, right? Unless you are undergoing menstruation. So great. So postmenopausal females, when they come in with vaginal bleeding, is kind of a red flag, something we should be concerned about. All right, so what are some other questions you want to ask Ms. Donaldson, knowing that she's postmenopausal and she's presenting with 2 weeks of vaginal bleeding? Okay, in the chat we have how heavy the bleeding is. Yes, absolutely, right? And one way we can ask that is, have you had to use things like pads or tampons, and how often have you had to use those? Great. What else do you guys think? Is there any pain in addition to the bleeding? Yes, absolutely. That's a great question to ask. Always important. Is there any pain, right? And that can help tell us, are there structural things going on? It can clue us into other etiologies as well for the vaginal bleeding. Great. Anything about past medical history that you guys think, or maybe like any screenings that she should have done, regular health maintenance things to see that she's up to date on? Anything you can think of? Yes, last pap smear. Yes, wonderful. So cervical cancer screening, super, super important. Cervical cancer is preventable if we have screening, right? And so even though she's postmenopausal, she's still at that age where she should be getting screening. So yeah, great things that you guys are thinking about. So here is what I had for some of the things to ask her. So description of the recent bleeding, any associated symptoms, when her last menstrual period was, even though she is postmenopausal, was it 5 years ago or was it just, 13 months ago? And also like when the menopause started. If she has any other like gynecological problems, right? So vaginal bleeding, something down in that area is bleeding. It can be other things as well, but does she have a family history of like ovarian cancer or endometrial cancer or cervical cancer? Does she even have a uterus? Maybe she's had a hysterectomy, right? A partial hysterectomy, perhaps. So that's another thing to ask about. And then because this is bleeding, like, is there other bleeding issues, like any bruising, nosebleeds, gum bleeding? Because perhaps this is not, this is a systemic issue from like having a sort of like bleeding disorder. In the past, did she have heavy menstrual periods? Did she have postpartum hemorrhages? That means, if she was pregnant before, after pregnancy, was that complicated by a hemorrhage? Sometimes after pregnancy, the uterus, it's supposed to kind of clamp down. You're supposed to massage it, and so that the blood vessels will constrict, and that you'll stop bleeding. Sometimes patients can have a hard time, their uterus has a hard time doing that. That's called a postpartum hemorrhage, and that can be an issue. Family history of cancer or bleeding problems, detailed meds is always important, and then up to date on any cancer screening. So even like mammogram, colonoscopy, cervical cancer screening, as you guys mentioned. Great. All right, so here's a little bit more about the case, and I'll let you guys read this. Oops, sorry. Didn't mean to move on that. So really what we're getting from the rest of this is that we know that it started 2 weeks ago, which is what we already knew, but we have additional details. It started out being bright red, kind of turned a little bit brownish color, then bright red again. She's had to wear some pads, but only changed them 6 to 8 hours, and really doesn't have any other symptoms besides just some bloatedness. Okay. And here's some more about her past medical history. So I'll give you some time to read through this, and we'll talk about some things that are pertinent from her history. Okay, first of all, are there any questions about any of the wording on here, or just any questions in general about her history? Okay, so let's start with past medical history and medications. From this part, like, what are some pertinent findings, or what's the pertinent history from here that we might want to pay a lot of attention to?
She's on hormonal medication for her postmenopausal symptoms.
Great, wonderful. And so, not to put you on the spot, but anyone, can answer too. What about hormone replacement therapy is important? It's kind of a guess what I'm thinking question, sorry, but I guess, are there any risks associated with being on hormone replacement therapy?
Could it restart her menstrual cycle?
That's absolutely a great question. I don't think in general I shouldn't start like ovulation, the actual menstrual cycle again, but as we'll talk about, estrogen and progesterone, especially estrogen, since it is a hormone that is really important in growing that endometrium, it can actually cause the growth of the endometrium and eventual like bleeding of that. And so it can look like having like menstruation again. So yeah, absolutely. So I think that this is the important thing to pay attention to from her past medical history. Additionally, she has hypothyroidism and hypertension, which can be risk factors for other, comorbidities. And obesity is always a risk factor for many different things, such as cancer. So that's important to pay attention to. From her gynecologic history, I think really important is that she has had she has had a history of no abnormal pap tests. So that's important, right? Greater cervical cancer risk if you have an abnormal pap smear or if you're not up to date. So that's something to pay attention to. Also, she has been pregnant 2 times. And both of them were live vaginal births and they were uncomplicated. So she doesn't have that risk factor of, postpartum hemorrhage type of deal. And then family history. The lack of family history of cancer is important to note. And then also it looks like she has some, cardiac risk factors because her dad has congestive heart failure. Her paternal grandfather, died of heart attack at 72. And then her mother, hypertension, type 2 diabetes, osteoporosis. So, okay. And if we need to go back, if you guys don't get all the notes, you have to write everything down, but we can always come back and refer to these slides as well. All right, so questions to consider. The first one we already kind of talked about. So what is the significance of menopausal hormone replacement therapy? In the next slide, we'll talk about this a little bit more, but hormone replacement therapy can be used for patients that are having, severe symptoms associated with menopause that are interfering with their life, such as hot flashes, right? So if somebody's like, I'm having hot flashes all day, I can hardly go to work and concentrate, you might want to consider putting them on hormone replacement therapy. However, there are associated risks with being on this therapy, which we will talk about. But does anybody know the screening guidelines for cervical cancer? Like what age we start, perhaps, how often individuals are supposed to be screened and have pap smears? What about what age we start? Is anybody aware of what age it's recommended to start getting pap smears? Start screening in the 20s. Yeah, great. So it's age 21 is what is recommended. Great. So let's talk a little bit about those two things, the hormone replacement therapy and the pap smear, just for a learning point here. So as I've already alluded to, hormone replacement therapy can be used in patients that are, experiencing, severe postmenopausal symptoms. And somebody that is, asymptomatic, is going through menopause, but they are asymptomatic or they have symptoms, but the symptoms are tolerable, it's just better not to put them on the hormone replacement therapy, okay? But this is just for patients that are having symptoms that are interfering with their daily life. So typically you'll give them estrogen and progesterone, okay? The reason you don't want to give a postmenopausal female estrogen without progesterone is if they still have a uterus, that can cause the growth of the endometrium, and that can cause endometrial hyperplasia and eventual cancer, like endometrial cancer. So those cells that are encouraged to grow because of the estrogen can develop mutations, and that can lead to cancer. So typically we give progesterone with it as well. However, it's important to note that individuals that are on estrogen as well as progesterone, they can still have that same type of endometrial hyperplasia, because there haven't been a lot of very good studies about what exact dose of progesterone you would need to be on with the estrogen to kind of counteract those effects. So you can still see that, but it's going to be a result in general of the estrogen. So yes, it's helpful for symptoms of hot flashes, but there is an increased risk of endometrial cancer, kind of just like I talked about with the growth of the endometrium because of the estrogen, breast cancer, heart attack, stroke, and DVT. One thing though is that being on hormone replacement therapy does delay bone loss. So when women go through menopause, the lack of estrogen does put them at an increased risk of osteoporosis. So you can imagine then being on hormone replacement therapy could actually decrease that risk. So really with patients, it's just like a risk benefit analysis, right? If a patient has a history, just had a heart attack, obviously you don't want to put them on this. But if they're having very severe symptoms, maybe their, family member has had osteoporosis, might be an okay thing to try. Okay, and then pap smears. So pap smears are, when we go in and we kind of like scrape a little bit of a sample off of the cervix, and you're screening for cervical cancer, which is caused by human papillomavirus, or HPV. So pap smears, it's recommended to start them at age 21. You can continue them every 3 years until age 30. From age 30 to 65, you can get them every 5 years. However, when you get them every 5 years, you would want to co-test them with HPV as well. So you would want to get a pap smear test and also test for HPV. That's just a way to do it every 5 years, so they're not coming in, every 3 years or whatnot. But really, you should continue getting pap smears up until, age 65, unless for some reason, like they've had a hysterectomy that's removed every single part of the female anatomy, like the genital area. So like the uterus, the vagina, and the uterus and the cervix. If they've had those for non-cancerous reasons, like for example, I don't know, they just they wanted to get hysterectomy because they were having really like bad menstrual periods, things like that, then that's okay to forego the pap smears. Okay. So that was just a little bit of a learning point. And, she had severe hot flashes, it said, which is why she was on the hormone replacement therapy. And it also said her mom had a history of osteoporosis. So maybe I could have helped with that as well. Does anyone want to give a summary statement for like what we know so far about this patient? And so a summary statement, remember, should highlight the features like epidemiology and risk factors. So like her age, is she postmenopausal, and then key clinical findings as well. Does anybody want to give a go at that? All right, that's okay. We'll just talk about it to kind of review this together. So remember, this is a 53-year-old postmenopausal female. She's on daily estrogen and progesterone. She has a history of hypothyroidism hypothyroidism on replacement therapy, the levothyroxine. She presents with intermittent light vaginal bleeding for the past 2 weeks without associated cramping. Her last menstrual period was 3 years ago. She is G2P2. That basically just means she's been pregnant 2 times and which resulted in 2 live births. She began menstruating at age 11 and she has no history of abnormal pap tests and no family history of cancers. So that's kind of our summary statement of what we know so far about this patient. So what are our differential diagnoses? Knowing a little bit more about her and what she presents with. What are you guys concerned about? What is on your differential? Endometrial cancer, yes, should certainly be on the differential. Endometrial cancer in a postmenopausal female who presents with vaginal bleeding, that should always be on your differential. So great. Anything else? I know her last pap smear was normal, but cervical cancer is always something to consider. So we could put that on the differential too. So some things to consider for the differential with vaginal bleeding in the postmenopausal female. We talked about endometrial cancer. One thing is it could just be endometrial hyperplasia. So it could be along that sort of sequence of events where like the cells start to increase in number, which is called hyperplasia. And then they incur mutations, and then that can eventually become cancer. So we could be like more towards the endometrial hyperplasia part of that sequence. Additionally, we could put cervical cancer on the differential too, but her last menstrual period, her last pap smear was normal. And then cervical polyps. So sometimes we can, even like endometrial polyps, sometimes we can have just these like normal benign like growths in the cervix and in the uterus, which can cause bleeding as well. And then hormone producing ovarian tumors. So sometimes this is more rare, but if you have a tumor of the ovary that is going to secrete hormones, those hormones can cause the growth of the endometrium. You can actually get a coexisting endometrial cancer with that as well. So all of those are things to think about. So here's like a more comprehensive table that talks about these things a little bit more. Proliferative endometrium, this just describes endometrium that it's not hyperplasia, but it's very similar to hyperplasia. Proliferative endometrium, if you remember, is what we see in the follicular phase of menses. So in premenopausal patients, this is actually normal if they're undergoing menstruation. Okay. But I think I agree with you guys in that like the endometrial, cancer or hyperplasia, whatever that must be, whatever it may be, I think that should be probably highest on our differential, especially because it's one of those things that we don't want to miss. All right, so here's the physical exam. I'll let you read through this a little bit and just point out the, excuse me, most pertinent findings. All right, so what from the exam sticks out to you? Is there anything that is quote unquote abnormal or any finding that we should pay most attention to? What do you guys think?
The obesity?
Yeah, obesity. I think that that's a good one, because obesity can be a risk factor for, many medical conditions. Additionally, obesity, when we're talking about like estrogen and the effects of estrogen on the endometrium when it's unopposed, when there's estrogen kind of without the levels of progesterone that we would need for it to suppress growth, that estrogen can be increased in the setting of obesity. And we won't go into why that is, but that's basically a risk factor is what I'm saying for like endometrial hyperplasia as well. But it looks like the rest of her exam is like relatively normal. But what other exam do you guys think we should perform in this patient? What are we missing? Or what other area of the body should we be looking at? So knowing that she's having like vaginal bleeding, and that, we have concern for potentially things like endometrial cancer, what area of the body should we perform an exam on?
Abdominal?
Yeah, so she had the abdominal exam, but absolutely like in that area, it's also like the uterus and things like that. So going kind of with the abdominal exam more to like the genitourinary system and that sort of thing is like the pelvic exam, right? So we want to take a look at, the uterus, palpate the ovaries, look at the cervix. That's all important. And that pelvic exam, is something that we don't do routinely on, every patient that's coming in for a follow-up visit, but for like gynecologic patients or somebody presenting with a new gynecologic issue or even like annual examinations, we will tend to perform, pelvic exams to be thorough and things like that to make sure you're not missing anything. So in her case, of course, though, a pelvic exam is certainly indicated because that might be where, the problem is. And so this is her pelvic exam. So with the pelvic exam, there's two things we can do. So one is just palpation. So palpation is just, they're lying down, their legs are kind of open, almost looking like a frog-like position, is that's what I say, kind of like when you're giving birth. They're in that position. And you use two fingers and you go in and you'll palpate the uterus as well as if you can palpate the ovaries, that's helpful as well. But what this can do is this can help tell us like, is the uterus rigid? Does it have any lumps and bumps? Sometimes those like polyps or those little fibroids, like fibroid tissue on the uterus, they're benign, but they can cause bleeding. So it's helpful to know if it's like a normal shape. And then the ovaries, if you can feel them, are they of normal shape? Are they enlarged? Is there concern for, an ovarian mass? Those sort of things. And then the next thing we do is we use a speculum to kind of go in through the vagina and to open up, pull apart kind of those vaginal walls so that you can see the cervix. And that is what we do when we want to do a pap smear, but it also just helps us to visualize the cervix as well. The cervical opening is called the os. And so if there were any like lesions on the cervix or like bleeding from like the mucosa of the cervix or erythema, things like that, discharge, you'd be able to see that. So it looks like in her case, the only kind of abnormal thing is that you can see a small amount of blood being wiped away from the opening of the cervix, which is the cervical os, but there are no lesions on the cervix. The cervix is movable and non-tender. It seems like the uterus is as well. You can't feel the ovaries because of her obese body habitus, so note that. But otherwise, it seems like things look relatively normal for an individual of her age. Okay. So has your differential changed at all? And what do you guys think the next best step is? So as far as like, cervical cancer, is this low on our differential or high? What do you think? With her last pap was, normal, and it looks like on the exam, on the speculum exam, we really didn't see any lesions on the cervix. So yeah, probably lower, absolutely. And so we're kind of, again, moving into what we were worried about all along, which is more of like an endometrial hyperplasia or cancer picture. So first thing, what about her medication? Do you think we should stop her hormone medication or consider it? Consider stopping it, sorry. And this is something that we can just keep in the back of our minds. And, after we do more of the workup and the diagnosis and everything and make the treatment plan, we can come back to it and say, hey, are we going to counsel the patient on, stopping this medication? Or are we not? So let's just keep that at the back of our mind then. But knowing that there's concern for like endometrial cancer and that the endometrium is within the uterus, what's the next best step for evaluation? What do you guys think? How are we going to evaluate if there's something wrong with the endometrium, if it's thickened too much, if there's cancer in there? What are some ways we can evaluate that? Ultrasound. Yes, wonderful. Great. So yes, there's a special ultrasound we can do. It's called the transvaginal ultrasound. And that can look at the uterus and the endometrial lining. It can actually tell us how thick the endometrial lining is. Because in this postmenopausal female, who's not undergoing menses, we would not expect her endometrial lining to be very thick, right? And so if it is, that might indicate that potentially there is hyperplasia or that there's cancer in that area. So an ultrasound is great. So what about anything else though? Once we're in there and we do, the transvaginal ultrasound, is there anything else we can do to confirm a diagnosis or maybe to look at like the cells? Great. Yeah. So a biopsy. So we should consider an endometrial biopsy as well, because if there is hyperplasia, that will tell us, are these like normal looking cells though? Or are we still on that like normal looking type part of the sequence? Or are we all the way over to where, these cells look very atypical and they've invaded the basement membrane and it's becoming cancerous? So great. So we'll do a transvaginal ultrasound, and we will do an endometrial biopsy. So first, though, let's talk a little bit about endometrial cancer. As I've already alluded to, it's, the lining of the uterus. Often the glandular portion is the part that becomes cancerous. That's called adenocarcinoma. So endometrial adenocarcinoma. It's actually the fourth most common cancer in women. And interestingly, smoking and the use of oral contraceptives decrease the risk. So this is not a reason to like smoke. Like women, don't say, hey, smoke so you decrease your risk of endometrial cancer. It's just something, interesting that has been found. It does happen to be detected often at an early stage because patients will often present with abnormal vaginal bleeding. And signs and symptoms are postmenopausal vaginal bleeding, bleeding between periods, pelvic pain, that sort of thing. And so as I was talking about earlier, this whole idea of the unopposed estrogen. So like the estrogen early on in your cycle normally is what's responsible for the growth of that endometrium. So anytime we have estrogen that is unopposed, meaning like there's not enough progesterone around with it, or just there's a lot of estrogen, we can have the risk of like growing that endometrium when it's not supposed to be. And so that's hyperplasia that can eventually turn into cancer if the cells develop, mutations and things like that. So certain risk factors for like unopposed estrogen are the following. So being on the estrogen therapy, with progesterone, but especially without progesterone, having cycles where you don't ovulate, late menopause, early menarche, so before the age of 12, menstrual cycle irregularities, Nulliparity, that's like when you haven't, been pregnant before, obesity, hypertension, diabetes, hypothyroidism, so on and so forth. So which of the following risk factors does she have? Of these, what do you guys remember? Yes, early menarche. So yeah, she had her menstrual period at like 11. Obesity, hypothyroidism. She's more than 35 years of age. Yes, absolutely. Hypertension as well, right? She's also on estrogen therapy. So less of a risk because it's the one with progesterone. But remember, like I said, like there's not a lot of good data about how the exact dosage of progesterone that's supposed to go with that. So being on hormone replacement therapy in general can be a risk. Awesome. All right. Okay. Oops, sorry. Okay. So we've already talked about kind of beat the bullet here, but what testing should be ordered to evaluate her bleeding? So we talked about the transvaginal ultrasound, which we will do, and the endometrial biopsy. We can also do a couple more tests. So because hypothyroidism has been associated with endometrial cancer and she has hypothyroidism, you might as well go ahead and check a TSH to see if she's adequately suppressed with her levothyroxine. Just because that test is really cheap to order, so might as well just throw it on. And then a CBC just to see, what her blood counts are. All right. And so this is just talking about how the transvaginal ultrasound can be really helpful in evaluating postmenopausal bleeding, because like I said, the thickness of the endometrium is what we're interested in. If it's very thick, so over 4 millimeters, that's considered abnormal, and you'll want to do like a biopsy. But in this patient's case, so because she's over the age of 45 and presenting with postmenopausal bleeding, we'll want to just go ahead and do the biopsy as well as the ultrasound. Okay. So you just want to order both in general, regardless of what the ultrasound says, you still want to do the biopsy. All right. So her results, her CBC and her TSH were actually normal. So that's good. But then here's her transvaginal ultrasound. So it says uterus of normal size, and this is the uterus we're looking at here. In fact, this is the opening of the uterus. So you can imagine, in pregnancy, this obviously becomes very wide and like the baby is going to be in there. So this would be like the endometrial part. This is the endometrium. And then as we move outward, it's more the myometrium or the muscle. So it looks like pretty normal in general. However, they note that the endometrium is 6 millimeters, so larger than it should be. Okay. And so I've kind of just, beaten this point home. But when we have the unopposed estrogen, that can lead to like hyperplasia. That's often benign. So like the cells are still normal, but they become hyperplastic. So there's many of them. And then over time, if that continues, they can develop mutations and develop into cancer, right? And that's called endometrial intraepithelial neoplasia. You don't need to know that word, but it's essentially when these cells do develop mutations, but they haven't invaded the basement membrane yet. And once it invades, though, that's when it's called carcinoma. So once it's leaving and invading like the muscle and, sort of things like that, that's when it becomes carcinoma. So it's kind of a sequence, right? And we like to catch it early so that we can reverse it and, prevent this sort of mutation to cancer step. Okay, and so here is her endometrial biopsy. So her endometrial biopsy read irregular and cystic expansion of the endometrial glands without worrisome changes, consistent with benign endometrial hyperplasia. Okay, so here are like those endometrial glands, as I was saying. So we know that endometrial cancer is from the glands. It's a glandular cancer. It's adenocarcinoma. So it's very possible that all of these glands that are, being produced now can eventually mutate and become cancer. That's why we need to watch this, and we need to adequately treat that, which we'll talk about. But in this case, though, benign endometrial hyperplasia and like simple hyperplasia progresses to cancer in like less than 5% of individuals. However, 5% is still, a big number when we're talking about, people that are diagnosed with cancer. So it's important to do adequate treatment. All right. So what do you guys think about her treatment? Does anybody know the treatment for somebody who has like benign hyperplasia of the endometrium versus like having actual cancer? Do we need to do anything? What do you think about, her medication, like we talked about earlier, perhaps stopping it? What are you guys' thoughts? Reduce estrogen dose or increase progesterone. Yes, great. I think that's a wonderful thought. So certainly that's something we can consider. I think in this case, like just stopping it altogether is probably stopping the estrogen part altogether is important, which brings us to the other point that in these patients, we actually often treat them regardless of whether or not they're on hormone replacement therapy. They're already on it. We want to stop that. But we treat them by giving them progesterone, actually, because the idea is that there's been some unopposed estrogen that's causing the proliferation and hyperplasia of this endometrium. And if we give progesterone, then that can counteract that and we can stop that from happening. So I think in her case, then yes, potentially reducing estrogen, that means just reducing it to nothing. So stopping the estrogen part and then having her be on the progesterone. So great. Yeah, I think that was getting at the whole point. So wonderful. So let's do that. And then anything else? Anything we want to counsel her on as far as like lifestyle changes go? So because like obesity is a risk factor, we could potentially talk about, just some general lifestyle changes, diet and exercise, really kind of maybe probing a little bit into like some of the barriers to, eating healthy and exercising, or if she is eating healthy and exercising, having that sort of conversation from a non-judgmental standpoint, obviously, in a place of like understanding is important. Okay, so then the progesterone, I already talked about that. So putting her on progesterone to counteract some of those effects that estrogen had. And in these patients, we'll want to repeat an endometrial biopsy in 3 months. So as you can see here, if somebody has hyperplasia with without atypia, this is like the flow chart for that. And if they have their uterus, then you'll want to put them on like progestin. And then you want to repeat the endometrial biopsy in 3 months because we want to do a follow-up to make sure that this is not progressing, right? To make sure that it has, gone back to normal, that sort of thing. And then so on and so forth, depending on what that biopsy shows. One thing to note too is that because we are stopping her hormone replacement therapy, she still experiences hot flashes. So there's other medications that are not as helpful, research has shown they're not as helpful as hormone replacement therapy, but it's still something to try instead of just saying, oh, stop it altogether and just deal with your hot flashes. So one of these is like low dose gabapentin. Gabapentin is a GABA modulator that is often used for neuropathy. So patients with like diabetes and they have like that burning sensation and pins and needles in their feet, gabapentin can help that. It can also help with hot flashes. So it's something we can consider with this patient too, starting since we are taking her off of her hormone replacement therapy. Okay. All right. Well, that is all I guess I have tonight. Does anybody have any questions? Thank you for participating. I hope you learned a lot. I think the main points of what's on the quiz I highlighted. So hopefully you do well with that. Any questions before we log off? Is it okay to rank fibroids low on the differential because the patient is postmenopausal? Yes. So Isabel brings up a good point. We didn't really talk about fibroids, which are like that tissue growth within the endometrium. Uterine fibroids, if they are like of the muscle, like leiomyomas, like that can be cancerous, like muscular tissue, or it can just be like benign, most often benign, but that can certainly cause abnormal uterine bleeding. Usually it's on the differential when we have patients who are like premenopausal. However, because postmenopausal females like presenting with it, it's typically like our red flag is up for like, oh my gosh, is this cancer, any sort of that thing. But it would still be on the differential, so, but you would probably have it lower just because they are postmenopausal. So yeah, great. No, great question. Thank you. All right, everyone. Well, go ahead and take the quiz, and thanks for joining in. It'll be, I think, 2 Wednesdays, and it'll be somebody else. I forgot what her topic is, but hope to have you guys join them that time as well. So thank you.
Thank you.